So thank you very much, Bernie. Good afternoon, everybody. It's lovely to be here with you. And I'm going to expand a little bit on what we have been able to do in remote assessment and examinations to respond to the changes that COVID has thrust upon us. So as you can see, we have to live and train with COVID now long term. And Bernie has told us how we have to think very much about how we make our assessments particularly meaningful. And certainly many of our trainees now have to undertake far more remote assessments than they ever had to. So we have to think about the important qualities of good supervision, and that it must be both normative, so it ensures that the trainee can provide high quality care, and it must be formative. So the supervision itself must be good. We must actually give them feedback on all aspects that they're undertaking, and it must be timely, and it must be very specific so that it's excellent and also helps provide this high quality care. But it also must be restorative. So it should be something that enhances the well-being and the development of the trainee overall, so they can maximize their potential. So I think it's been quite a change for all of us to have to undertake more remote consultations. And I'm going to mention video consultations using Attend Anywhere specifically. But I'm also going to say that many of our trainees had to undertake telephone consultations. Now, as a glaucoma specialist myself, undertaking a glaucoma consultation by phone is not going to give me a lot of answers as to whether a patient has changed or we have worries. But it did allow us to check in with patients as to whether they'd become symptomatic, or whether they were taking their drops and getting repeat prescriptions, particularly if they were shielding and struggling at home. It also allowed us to phone patients directly if we'd undertaken a virtual review, perhaps of measurements that had been done, and to then look at writing to them and giving them information personally. So certainly the Academy of Medical Royal Colleges in the UK recommended that we should write to patients directly. And after our virtual review clinics, we do that much better. So again, for trainees, this is about checking that they're able to write a letter that is in a language that's comprehensible to our patients and makes sense to them and makes them feel empowered in their care. So I think at the beginning of this, we were all thrown into a strange situation, and perhaps we didn't think too well about how we might train people in remote consultations. But it is really important because, of course, we all know that watching a Zoom meeting rather than being in a live meeting can be quite tiring and difficult. Why is that? Well, it's because we have less clues from body language than we do if we're sitting or talking to people. And so parts of our brain that we're not using otherwise have to be switched on differently for us to be alert to these changes and to think about how we might find out how somebody is feeling. So I think that's why we're all more tired after we've been on a Zoom meeting. And if we're going to have video consultations with our patients, we have to be alert to those subtle clues. But it's also a really good time for refining your relevant history taking and getting trainees to really focus in on what's important. So maybe at the beginning, considering a script of pro forma and getting them to develop it. And then using a proper framework to give feedback on how the trainee structures their consultation. Do they cover the patient's understanding, their concerns, the expectations of this consultation? Is there a good closure effectively as well? And then giving feedback to them on all of that, including their written letters afterwards. And this can be done very well for our shielding trainees, as Bernie mentioned. So, for example, our oculoplastics and primary care team found Attend Anywhere particularly useful. Both the trainee and supervisor have a link to meet with the patient. The patient comes in from a waiting room, and then they're able to share their scans, pictures, or whatever as required. What can happen then is after the trainee has perhaps taken the history, they can ask the patient to wait again for a moment, and the trainee and supervisor can discuss what needs to be done. And then the patient's invited back in again from the waiting room, and the trainee can give the feedback and then present to the patient what needs to be done. And again, at the end, the supervisor can give further feedback to the trainee. So that's not that different, particularly perhaps from what we do in clinic. And one of our consultants who was shielding for a while was able to do this with their trainees regularly. So I've alluded that giving feedback on virtual assessments is important. And again, there's quite a lot of things you can make an assessment of with that trainee, and you can do it via Zoom. So understanding and interpreting results, the decision making for patients, the follow-up and future planning for their care, as well as their communication. You can also think about all those other generic professional capabilities that the trainee should be able to demonstrate and needs to continue to develop despite COVID. So, for example, remote review of presentations or a teaching session that's done online. If you have good structured feedback, thinking about the different steps of what they've done and how well they've done that will also be very important and useful. And that could be true about a research project in the same way, or a leadership project. So in your educational supervisor role, instead of being on Zoom as here with lots of people, you're going to be in a one-to-one relationship with trainees. And at first, I think we worried that this may seem a little strange for them, but actually they're often in their home environment when you're doing this, so they can be more relaxed and able to discuss freely with you. So as long as you make regular contact and update at mutually agreed times, it can work very well. And for some of our trainees who were shielding, this was weekly, at least with their supervisors. And it's important to think about their well-being. Certainly, I think the focus in the UK for NHS staff members on well-being has really changed recently, which is very helpful. You can talk about those generic capabilities so that they're still getting on with other projects, their research projects, if they are not in a laboratory, their audit projects or quality improvement. You can also encourage them to be planning ahead and talking to their clinical supervisors about how they're going to take advantage of those opportunities. And it's a good time to start thinking about what the long-term career plans and aims are, and what evidence they're collecting long-term in their e-portfolio. So of course, this year we had to do our national recruitment remotely, and we normally have 90 consultants undertake recruitment in a large hotel actually in the southwest of England, with approximately 250 candidates who are seen on 14 tracks of going around 3 sets of stations. So we were very concerned that if we were going to simply be doing this by assessing their portfolio, that we kept some of the things we thought were very important. So our trainees undergo a machine marked test, which is a multi-specialty recruitment assessment on problem solving and managing professional dilemmas. And this is used also by GPs, by psychiatry, and other specialties. And so we remove perhaps the lowest scoring applicants from that only. And on this occasion, this year, as we had 255 slots, we had a record number of people applying for ophthalmology with over 600. So we shortlisted down to 255 slots on their portfolio, which they submitted completely scanned remotely and was assessed by 2 assessors. But we thought it was really important that we could check they had good communication skills, as it's part of our normal recruitment process. So we had an online patient consultation by Attend Anywhere that was marked by 2 assessors remotely, and this went extremely well. So now I'm going to show you some slides that have been prepared for me by our exams team, because we had to make massive changes as well to our examinations. So our current exams are that we have an undergraduate prize exam, the Duke Elder, and we have then the RCOphth Part 1, the refraction certificate, and then the Part 2 is taken as 2 halves, a written and then an oral exam. And we also have a certificate for laser refractive surgery. And of course, we were stuck in lockdown. We had examination venues restricted, the hospital that was going to hold the exam, or in many situations, the options were closed. We had examiners who couldn't also attend or travel. We had candidates who were going to have problems with that. We thought that using masks could possibly lead to communication problems, and that face-to-face, we would be putting the patients we'd examine at an additional risk unnecessarily. And of course, then false social distancing would make it difficult to set up, and real patients we'd be therefore unable to use. So we had to put in new mechanisms in place to develop exams to run well during COVID. And this is an example in the refraction stations. So for the part 1 and part 2 written exams, we already have these undertaken in the driving test centres where patients go for their recruitment SRA tests. In fact, these were closed but open again for our recruitment, luckily, but not open enough for us to do our exams. So we moved to online proctored delivery, where candidates take the exam at home and are watched by a live proctor through their webcam. And we have a ratio of 1 live proctor to 6 candidates. So it's available to anywhere in the world without having to come to the UK. And it's been run 3 times successfully. And we've also run the part 2 exam with great success too, having an exponential increase actually in our global candidate numbers because of this online delivery. Again, for our refraction certificate, we could not use real patients. So we used retinoscopy OSCE simulators, and therefore the exam became more retinoscopy based than full refraction. But the GMC, our General Medical Council, approved these changes, which had to be submitted to them. And we've implemented this as well. We have iPad-based electronic answering and marking, so there's now no subjectivity in that. And with our strict protocols in place, we were able to run this with the candidates attending live, but to undertake the retinoscopy stations. And it ran successfully twice, and we were able to put more candidates through, which helped with the backlog. And then for our part 2 oral examination, again, as we couldn't use real patients, we went to modified OSCEs. So because we were concerned that candidates must show that they could examine the eye as well as pick up the signs from a video, they had to undertake those assessments, which are normal workplace-based assessments in our curriculum. They had to undertake them again with an examiner local to them to show that they could undertake them properly. And then on the day, they had clinical OSCEs with videos that had been filmed and edited at the host hospital where the patients had already been planned to come. So they came up socially distanced just to the hospital and had videos made of them. And this went very well with our electronic marking, and now has run 3 times and quite close together in 21 really, in order to cope with the backlog for our trainees. For the certificate for laser refractive surgery, as this is a specialist examination that's small, it had been on hold until the autumn of this year, where again it will be delivered online. And the viva is face-to-face without patients. So the future, of course, for us is that these post-COVID examination changes may mean that we change our exam structure somewhat overall. And we're hoping in presenting to the GMC changes that embed some of these as well in the future. And it will also allow us, with our new international host centres, to facilitate more global attainment of the exam. It's important to note, of course, that full RCOphth is recognised by the GMC for UK registration, so PLAB exemption. So in the future for the refraction certificate, we would like to take the best of both, have our simulated retinoscopies, have a live retinoscopy and a subjective refraction. And we're awaiting the decision by the GMC on this, but it would be implemented in the middle of next year if possible, pandemic allowing. But having moved to this electronic answering and marking on iPads, we'll be keeping that. For the part 2 oral exam, Again, we want to continue with our simulated scenarios, but have some face-to-face volunteer patient examinations so that that will be considerably reduced numbers of patients required. And again, approval is needed by the GMC to implement this next year. And what about international exams? Well, we already currently go out to Malaysia, Singapore once a year and have a Part 2 oral there, as well as undertaking the refraction certificate. So our proposals in the future are that we may be hosting the exam sittings in India, Egypt, Trinidad and Tobago to begin in spring 22. And then the Part 2 oral, again to be in Trinidad and Tobago in spring 22 and in India and Egypt in October of that year. And we hope that in southern India, the following year in 2023, we'll be holding the exam again. And we're also looking at the introduction of a new qualification, the RCOphth, that would be available globally. And this would be about recognising the successful completion of both of the written components of the FRCOphth Part 1 and 2. So this has to go to Privy Council in the UK before this can be confirmed. But then we hope that hosting that with the refraction certificate and the Part 2 oral outside of the UK, we'll be able to encourage more candidates to complete our full fellowship examination, as we know this is held in high regard now. And if you're interested in being an international examiner, you can have a great time doing this. We need more international FRCOphth examiners. Training and accreditation will be provided by us, and then it will be mandatory, of course, to do examinations with our examiners as well. And if you're interested, please contact our head of examinations, Dylan Costello, at dylan.costello@rcophth.ac.uk, and he will tell you more about that. So thank you very much.